Battery. Sampai tertulis semua. Recording off just
Actually, we plan to see each of the patients in one in each of the trimesters, but I think this baby is not in position. However, we will see what all we have to see in the first trimester scan. So in the initial sweep itself, we have to see how the uterine contour is, so that there is no any if there are not any uterine anomalies, you can pick up in the first trimester. So we have to just sweep and see how the uterine contour is. And if there are any adnexal masses or cysts, you can see on either side. So this is a fetus. The first trimester scan is usually done to know the location, then viability and number of the fetuses. This is a single fetus with a good cardiac activity and movement. So we'll see if at all it is possible baby is in position, we'll see NT, otherwise I will show you what all we have to see in a NT scan along with the NT. So actually this baby is also tired, I think it is in the prone position. But we should not take CRL in this position, it should be in the opposite way. So this is the skull, we have to look. We have to look whether the skull bone is formed, it should be calcified, and this is a butterfly sign, that is choroid plexus. And this arrow mark is nothing but transthalamic plane. So in this plane we have to see for the BPD.
The location of the aqueduct of Sylvius. Aqueduct is
very large in the small, the first trimester fetus. So you can see the cystic form there. So there should be a gap here. If this activator goes and touches the posterior occipital bone, then we call that just like a crashing car. So that is a crash car sign. When you find that, then you must try and look for a small meningomyelin. Please continue, Dr. Maxilla should be continuous, mandible should have a gap, and there are two nasal bones. So apex is formed by two nasal bones. I request all our audience to ask any doubts. Please feel free to ask any doubts.
And you can see this is the stomach bubble, and on the same side you are able to see the heart apex. So the sinus solidus.
Get the best view, it is always the best way is to allow the baby to jump up and down, move, and then freeze after some time, and then go back in the silly loop and get the best possible section. both the sides. And here you can see down below, this is femur, knee, leg and a foot. So 3 sections of both the upper and lower limb should be confirmed in this first trimester scan. Baby has put his hands over the nose. Hypogenic lines. This is orbit. So you can see an anechoic structure with the dot inside. These two are orbits.
Those dots are the lenses. In anorthoscopia, you will not find those dots. Those dots.
So this is the heartbeat. This is a blood flow. You can see the ventricles and the atrium. This is a 4-chamber view in color Doppler. This is outward tracking.
So we can image the fetal mass with the help of the color Doppler. So you need to have 2 parallel inflows mixing and then 2 outflows forming a tick sign. It's a normal height. So for LT scan, remember rule of 2, head 2 planes and inflows, outflows, 2 sections we take, spine in 2 planes. So usually we follow the rule of 2 in LT scan. Trying to do here is trying to get the tricuspid valve. Looking at the tricuspid valve flow is part of the extended protocol for an MT scan. Tricuspid regurgitation is a marker for Down syndrome. Dr. Divya, can you please repeat the PW? So you have, in the inflow you have the atrial wave and the ejection and the atrial wave. And then you have an outflow. The regurgitation will appear here during the ventricular relaxation. Please continue. That's a mixed sagittal view.
Actually, this patient is little high BMI, so couldn't provide you the better image. For a proper NT image, it should be mid-sagittal view, and it should be covering the head and the upper thorax. Image should be covering only the head and the upper thorax. So we have to see the figures in the neutral position with neither hyperextended or hyperflexed. We have to see this amniotic membrane also separate from this NT. And the distance between the occipital bone and the skin should be taken at the maximum diameter. We can take 3 measurements in 3 different images and consider the larger one. Roughly you can see here, there are 2 echogenic lines. The lower one is the nasal bone, upper is the skin, and this is the echogenic skin tip. And it should be made, the caliper should be placed on the echogenic line. And this bright line is the occipital bone, and the distance between this occipital bone and the skin has to be measured, and this is the amniotic membrane. It should be seen separate from the skin. Actually, first trimester cervical length doesn't have that much of guidelines to how to measure and what is the cutoff length. The uterine artery can be traced after tracing the cervical canal. Just slide it on either side. You can see at right angles, the uterine artery is going on the right angle. Cervical canal, we are sliding onto the right side. Now we are able to see
What are we trying to do here?
Right mid-sagittal plate, but slightly towards the right side. We have to look for the ductus venosus. So we have to look where the umbilical vein meets the fetal heart. Actually, this baby is jumping now.
It's actually very difficult because the vessel itself is very small, and when the baby is moving a lot,
Not only single wave, and it has moved up.
we'll be looking at the protocol-based approach for a intra-distal scan. one and all. Thanks Dr. Radhalakshmi ma'am and Dr. Venkatraman sir for giving this golden opportunity to share my experiences on this prestigious platform. And if mind doesn't know, eyes can't see. We basically are the gynecologists and have the eagle's eye. So first I will do survey scan by doing superior inferior transverse sweep. From this sweep, single sweep, we know that head is down and the breech is up and cardiac activity is good and the placenta is anterior, lighter amount is good. So with this little survey scan, we can see all these findings. Then coming to fetal biometry. So fetal parameters to be measured for assessment of the fetal size are biparietal diameter, head circumference, abdominal circumference and femoral length. First coming to biparietal diameter, it should be taken in transthalamic plane. I will demonstrate this one while demonstrating what are all the checklist of findings to be seen in the biparietal diameter. I will demonstrate while demonstrating the fetal head. Taken outer to outer measurements at the widest part of the skull. Of all the fetal parameters, I will be little bit careful about biparietal diameter because it is depends on the shape of the head. If there are any alterations in the head shape, head size, head circumference is the best for the assessment of the gestation age. Then coming to head circumference, outer to outer edge of the calvarium. By using the ellipse approach. Abdominal circumference. The landmarks that should be visualized in abdominal circumference are spine in 3 o'clock or 9 o'clock position, spine in the 3 o'clock or 9 o'clock position, and umbilical vein at its anterior 1/3 of its position, and the stomach bubble. And kidney should not be visualized in this position. And symmetrical ribs must be visualized on either side. Abdominal circumference is measured outer to outer measurement including the skin line. Then amniotic fluid measurement. It is taken in 4 quadrants. Placing the transducer perpendicularly to the maternal position, and 4 vertical pockets are taken. Whereas amniotic fluid index is superior in assessing the polyhydramnios. Location, homogeneous. In the placenta, if the patient has any history of the uterine surgeries or the prior cesarean section, we should look for 3 areas mainly. Here the placenta is homogeneous, whereas the role of the placenta accreta spectrum, the placenta in the placenta accreta spectrum, the signs are the abnormal lacunae. Here the placenta is homogeneous. This is the retroplacental zone. This is the myometrium underlying the placenta. So these these are the signs. In case of the placenta accreta spectrum, there are the abnormal lacunae, and there is the loss of the retroplacental zone. There is the thinning of the myometrium. So we must also assess the distance of the placenta to the internal os to rule out the placenta, low-lying placenta or the placenta previa. So coming to the fetal brain. Fetal brain is assessed in 3 planes. One is the transventricular plane, other one is the transthalamic plane, and the last one is the transcerebellar plane. This is the basic examination of the fetal brain. In the transventricular plane, what are all the checklist of the findings are this one is the midline fox, and this one is the cavum septum pellucidum. The midline fox must be continuous except at this cavum septum pellucidum, which is the echolucent structure, and it is longer anteroposteriorly and shorter in the transverse diameter. So these are the anterior horns of the lateral ventricles, and these are the posterior horns of the lateral ventricles. So coming to posterior ventricles, these are the medial wall of the posterior ventricle. This is the lateral wall of the posterior ventricle. So we must see the margins of the lateral ventricles for any nodularity and irregularity. This echolucent area is the CSF. Echogenic part is the choroid plexus. This hypoechoic structure is called the central cortex. Another important point is the measurement of the far ventricle. This is very important. This measurement is into-it measurement. And also at the level of the parieto-occipital sulcus, when we join these 2 calipers, the line must be perpendicular to the wall of the lateral ventricle. We must also have the practice to visualize the near ventricle, because sometimes if unilateral ventriculomegaly, which affects the proximal ventricle, may be missed. We won't see this near ventricle or proximal ventricle. CSP in the axial plane is a marker for the corpus callosum, for the presence of the corpus callosum in the mid-sagittal plane. This is a transthalamic plane, passes through the both thalami, and here is the third ventricle. And the CSP must be visualized in all three planes: transventricular, transthalamic and transcerebellar plane. This one is the transcerebellar plane. The checklist of the findings are the CSP and both cerebellar hemispheres, echogenic vermis and the fourth ventricle. So, these are the hypoechoic cerebellar hemispheres. This is the echogenic vermis. In this plane, we can't see the fourth ventricle. So, for getting the visualization of the fourth ventricle, we have to move the probe inferiorly, little bit inferiorly. This is the fourth ventricle. So, vermis is present between the fourth ventricle. This echolucent part is the cisterna magna. If there is any communication with of the fourth ventricle with the cisterna magna, so we should think of problem in the position and size of the vermis. So we must extend our examination by doing the fetal neurosonography. Measurement of the TCD, transcerebellar diameter, that is outer to outer measurement. This is most important, and measurement of cisterna magna is from the posterior aspect of the cerebellum to the outer to the inner aspect of the occipital bone. Then coming to the examination of the fetal spine. Fetal spine must be seen from the first cervical vertebra to the last sacral vertebra, that is S4 is the last one to be ossified in the second trimester. So, fetal spine is examined in three planes. One is the mid-sagittal view, second one is the axial view, third one is the coronal section. This is the mid-sagittal view of the fetal spine. So, in the sagittal view, what are all the checklist, mid-sagittal view, what are the checklist of the findings are the skin continuity. A good amount of the lichen must be there, and these are the posterior ossification centers. These are the anterior ossification centers. These two converge at the tip of the sacrum to form the sacral taper of the sacral tilt. This is the spinal cord. So the best plane to visualize the spinal cord is the sagittal section. So this is the tip of the conus. The vertebra, the height of the vertebra is more than the intervertebral distance. So the counting of the vertebra is this one is the S4, S3, S2, S1. So counting of the vertebra is the last vertebra to be ossified is the S4, and the conus medullaris corresponds to L2 or L3 level. If there is any tethered cord, the conus medullaris extends beyond the L2 or L3 level. Skin continuity, this one is the most important. There must be a good amount of the lichen. This is seen as a echogenic distinct line, beautifully seen. And then coming to the coronal section. These are the anterior ossification these must be in line and form the track. If any one of these are off this line, we must think of the hemivertebra. So hemivertebra are best diagnosed in this coronal plane. And these are the iliac wings. And these are the thoracic vertebra. But skin continuity can't be examined in this plane. Then coming to axial plane. In the axial plane, the checklist of the findings are the this one, 3 ossification centers. This one is the anterior ossification center, which is larger, and these 2 are the posterior ossification centers. And this is the spinal cord echorescent structure with a central dot. And skin continuity must be examined in this plane. Thank you once again, Foxy members, for giving this opportunity. Next systems will be examined by, demonstrated by my colleague Dr. Manjula. Thank you for patient listening. Yeah, ma'am. This is the perianal complex, ma'am. Here, this hyperechoogenic structure, this is the anal mucosa, and hypoechoic ring, it is the sphincter muscle. And usually we should see after 24 to 26 weeks of gestation. It is more clearly visible in the later gestation. Ma'am, shall I proceed? Yes, Doctor. Ma'am, shall I? Yes, please proceed. Yeah. And then we should assess arm and long bones and their mobility, symmetry, alignment and movement. And no need to count the fingers and toes. Usually we will take the measurement of one femur. And if we find any abnormality, then we should measure all the long bones and we should compare with the standardized charts. And if you see any abnormality from the abnormality, then we should counsel the parents regarding possibility of evolving skeletal dysplasia and possibility of associated genetic and non-genetic syndromes. And this is all about the fetus. Now we are moving to the cervix. Usually we will measure the cervix by using the translational probe, and it needs consent from the mother. Sorry, I forgot to demonstrate the face. So the face is examined in 3 views. They are modified coronal view. This is the modified coronal view, and this is the mid-axial section of the face, and this is the axial section of orbits. And in the axial section of the orbits, this is the lateral axial section. Here you can see the 2 orbits and the lens inside the orbit, and the presence of the 2 orbits should be documented. And this is the nasal ethmoidal complex. The space present between the 2 orbits is equal to the diameter of the one orbit. This view helps in the diagnosis of unilateral or bilateral anophthalmia in present. Actually, position is not good for us. Shall I take one more patient, another patient now?
Thank you, Dr. Manjula. I think we'll call it a day. It's been a long day. And I thank each and every one of you who are still present here for being up with us. And I thank Radhalakshmi Madam for this wonderful conference that she has pulled off. And thank you all my colleagues who have helped us arrange this workshop. I request Radha Lakshmi Madam to present our young enthusiastic
Momentous is our
fetal specialist with the
Momentous is
momentous.
ముందు కదా
I request all the coordinators for the ultrasound workshop to come onto the dais.
వెంకటేష్
We want to honor them with momentous.